So good morning everyone. So I'll be speaking on spectrum of viral keratitis and its management. So we know viral keratitis is basically divided into two types, that is herpetic and non-herpetic eye disease. The herpetic eye disease is again subdivided into herpes simplex and zoster, whereas non-herpetic is mainly adenoviral. So the main feature that differentiates a viral keratitis from bacterial, fungal and other types of is its recurrence. So which is mainly stromal and endothelial, which leads to scarring and neovascularization, and it is a cause of the major morbidity even when the disease is inactive. So based on the type of response, it is divided into infectious, immune and neurotrophic, where based on anatomic location it can be epithelial, stromal or endothelial. So based on these two types of response, it is broadly classified into four types, so which I'll be discussing in my next slides. So the infectious epithelial keratitis is mainly can occur as corneal vesicles or dendritic ulcer or geographical ulcer. So the corneal vesicles usually appear as small raised vesicles which are analogous to the vesicles on the skin surface. So these patients usually present with pain, photophobia, watering and defective vision, and these patients are mainly treated with topical antivirals which should be started at least 5 times per day until the vesicles disappear, and then should be tapered 3 times a day for another 1 week. So at this stage topical steroids are contraindicated and lubricants can be given at this stage to relieve the symptoms. So this stage should not be confused with the microsporidial keratitis, which have small creamy lesions in the epithelial surface which have stuck on appearance. So these patients usually give the history of fall of rainwater or dirty water in the eye, and these patients are usually treated with lubricants with or without epithelial debridement and which are confined to the epithelium. So next comes when this corneal vesicular stage, when we treat the patient with topical steroids or if the patient is immune suppressed. So these patients can develop a linear branching pattern like this, and which have large terminal bulbs with an inflammatory epithelial border which has active viral replication. So these patients are again treated with topical antivirals 5 times per day until the ulcer heals, and then should be tapered to 3 times after another 1 week. So next, when the dendritic ulcer is again treated with topical steroids, or if the patient has immune suppression, he can go into develop geographical ulcer which has this geographic pattern, and these patients have a scalloped edge, and they also have the inflammatory border with active viral replication. So these patients are again treated with topical antivirals 5 times per day until the ulcer heals, and at this stage the head study they have done, and they have seen that there is no benefit of adding oral SCV to the standard topical treatment to prevent future development of stromal keratitis. So again, a history of HSV epithelial keratitis is not a risk factor for recurrent epithelial keratitis. So the next stage is the stromal keratitis. So here we have two types. One is immune stromal keratitis and necrotizing stromal keratitis. The immune stromal keratitis can be disciform or interstitial keratitis. So mainly the stromal keratitis is due to immune response to the viral replication in the stromal keratocytes. So we'll see this immune stromal keratitis or disciform keratitis has central corneal edema which is surrounded by clear stroma. So these patients should be started with prednisolone phosphate at least 8 times per day and should be tapered for 10 weeks, and these patients can be added topical antivirals or oral SCV. And we have to remember that according to head study, the addition of topical steroids showed faster resolution and less treatment failure compared to patients who are on placebo treatment. And they also shown that there is no benefit of adding both oral and topical antivirals at the same time. Just give one, either topical or oral antivirals. So the next is a necrotizing stromal keratitis. Usually these patients have yellow to white stromal ulceration surrounded by dense infiltration and with a clear stroma around. So these patients usually this dense stromal infiltration is due to hyperimmune response to the viral replication in the stromal keratocytes. So these patients again should be treated with topical antivirals until the epithelial defect heals, and once the epithelial defect heals, you can give topical steroids and oral or topical antivirals like how you have treated an immune stromal keratitis. So according to head study, again here there is no benefit of giving both oral and topical antivirals to prevent future development of stromal or keratitis or iridocyclitis. So this is a case of recurrent stromal keratitis. So here this patient is almost coming to me the third time. So even though I keep him on prophylactic antivirals, once I stop the prophylactic antivirals, again he comes back with recurrence. So according to head study, the prophylactic antivirals 400 mg twice daily at least reduce the rate of recurrence by 41%. And they also shown that as recurrence is associated with scarring and vascularization, at least a low dose prophylaxis is recommended at least for 1 year or longer in patients with recurrence. So this is again a recurrent HSV keratitis. You can see dense scarring, new vascularization and edema, and these patients, so according to head study, again the epithelial keratitis is not a risk factor but epithelial keratitis, but we have to remember that recurrent stromal keratitis is definitely a risk factor for stromal keratitis by 10 times, and they have seen that stress, UV exposure, contact lens wear and systemic infections are not associated with recurrence of ocular HSV. So coming to endotheliitis, this is also an immune response to the endothelial cells which lead to corneal decompensation with stromal edema and epithelial edema. So these can present as either disciform keratitis which have clear disc edema with keratic precipitates only confined to the disc shaped edema. Again we have the linear endotheliitis where the keratic precipitates are confined to a linear pattern and with the trailing corneal edema. And in diffuse endotheliitis, we have diffuse corneal edema with the dispersed keratic precipitates and corneal edema from limbus to limbus. So this is a disciform endotheliitis. We have keratic precipitates and edema confined to a disc-shaped form. In these conditions, patients should be treated prednisolone phosphate 8 times per day and should be tapered for 10 weeks. And here definitely there is a role of oral acyclovir which should be given at least 5 times per day for 10 weeks, which helps in better resolution of iritis. So neurotrophic keratopathy, usually these patients, they first initially present with punctate epithelial erosions which then progress to persistent epithelial defect, and these patients usually have an oval shaped ulcer either centrally or paracentral inferior part of the cornea, and these patients should be treated with topical lubrication, preservative free artificial tears, gels and ointments, and punctal occlusion helps in better resolution. Adding of oral tetracycline or doxycycline helps to reduce the mucus produced and helps in healing. And these patients can also be given 20% autologous serum which is effective in stages 1 and 2. But if the patient doesn't heal with this above treatment, then we have to go for surgical treatment like tarsorrhaphy or palpebral sling or botulinum A toxin in the levator muscle. Conjunctival flap can also be considered, but poor cosmesis usually we do not prefer, and amniotic membrane transplantation is definitely another good alternative if you go for surgical procedures. So the next comes is the herpes zoster ophthalmicus. This is due to viral reactivation along the trigeminal nerve, and 50% and we have to remember 50% of untreated patients will go to develop ocular complications, and these are the most common types of presentations like conjunctivitis, uveitis, keratitis, episcleritis and chemosis. So when we see a patient within 72 hours, always start with 800 mg SEV tablet 5 times for 7 days, and other alternatives are valcyclovir and famlocyclovir, and this at any ocular presentation, this treatment should be started, and patients, it reduces the risk of ocular complications by at least 20 to 30%. And patients, if it does not prevent post-herpetic neuralgia, but reduces the duration of pain by at least 50%. So finally, the points to remember: in patients with epithelial keratitis, there is no benefit of adding oral acyclovir to prevent future development of stromal keratitis. And in patients with HSV stromal keratitis, always start topical steroids which have faster resolution. So in patients again with stromal keratitis, there is no benefit of adding both topical and oral antivirals. And with patients with iridocyclitis, always give oral acyclovir 5 times for 10 weeks, and topical steroids help in better resolution. And in patients with recurrent stromal keratitis, always give prophylactic oral acivir for at least 1 year. And remember that stress, UV exposure, contact lens, all these are not associated with recurrence of ocular HSV. And I would like to thank the scientific committee for giving me this opportunity. I would like to invite Dr. Ginu Priya for our next presentation. Thank you very much.